Hello, I'm Matthew Weinstock, Managing Editor for Modern Healthcare. And thanks for tuning into The Checkup, an interview series where we talk with healthcare executives about key issues in management and leadership. Joining me today is Amy Perry. She's Senior Vice President of Integrated Care Delivery and the CEO for the Hospital Division at Atlantic Health System in Morristown, New Jersey. Amy, thanks so much for joining us today.
Thanks for having me, Matthew.
So one of the key things we want to talk to you about is the process that Atlantic Health System is using to bring back elective non-COVID related procedures, which I know you've started to do. But first, I was hoping you could give us a sense of just sort of where Atlantic Health is in terms of your coronavirus cases. I saw on a Facebook Live that your CEO talked about a couple of weeks ago that you've actually seen about a 35% decline in admissions for COVID-19 cases. Is that right? And where are you now?
Yes, we've had a significant decline from our peak. We have seen almost 5,000 admissions for COVID, and additionally 5,000 emergency room treat and release COVID patients. So this has been a very significant part of our patient population over the last 8 weeks. But now we have significantly less, a little bit less than 200 patients across our health system with COVID, and our non-COVID patient population is a significant majority of the patients that we have in-house.
And so as you think about the 8-week period, what kind of financial strain did that put on Atlantic Health System where you've had to postpone or put off a lot of the elective procedures or so-called elective procedures?
It's had a significant financial impact because of what we had to do to handle the surge. So it's not very easy to quadruple your critical care beds within a week. I would say that that's an incredible feat, and the amount of resources that it takes from a facility's equipment, supplies, team member deployment is really quite beyond your wildest imagination. And so those expenses, coupled with the fact that the elective procedure volume dropped significantly, had a dramatic impact over the last couple months. And so we are working through that right now.
Can you put a number to that for us of sort of a revenue decline?
It's significant. It's definitely more than $100 million.
Okay. So let's talk about bringing some of those cases back now. I understand you're ranking some of the procedures as you bring them back, sort of a 5-tier rank. Is that right?
That is correct.
So how does that work?
Yes. So it's a ranking system that we've used throughout this crisis. Over the last 8 weeks, at no time did we shut our emergency department down. So I just really have to make sure that I emphasize that as a health system, this isn't a reopening. We've never had the luxury of closing, actually. And so we have focused on taking care of our sickest patients. We have a trauma center, so we took care of trauma patients throughout this ordeal. We took care of brain tumors. We had stroke neuro procedures. We had heart surgeries. And on the happy side of things, we delivered more than 1,000 healthy babies during the last 8 weeks. So we have continuously cared for a non-COVID population this entire time.
So, but as you bring back some of the cases that weren't there, how did you decide to do sort of a ranking and level them off?
Yeah, so we have the number one in the surgeries that continued throughout, we would categorize as number one, life-saving. And those procedures, if we didn't intercede in 72 hours, and we called that time to impact, that we had to do them, and we moved forward on all of those. And then our second level, we called urgent. And basically, again, with a time to impact score. So essentially, if somebody's health could be irreversibly impacted if we didn't intervene we intervened. And so we want to make sure that none of our patients suffer short-term or long-term because we're not taking care of their patient or their issues. And so now we're on really dealing with the third level, which is essential, which is things that had maybe a 30-day or 60-day time to impact, but we're there. We're at the 30-day and we're at the 60-day. And so now we're putting all of those patients on the schedule. So our key goal is to ensure that nobody's health is negatively impacted because of a delay. So all of these, our decision making revolves around the time to impact for our patients.
What impact did this have on readmissions, on cases where a patient may have had to come back for an infection, and how did you handle that?
Yes, and we did handle all of our readmissions as necessary for somebody who had a unforeseen condition after they left our walls. But of course, like many of the other hospitals that you've heard of in the community, we have accelerated our telehealth capabilities dramatically. We went from essentially 50 telehealth visits a day to more than 3,500 televisits a day in the matter of a couple weeks. And so because of the hotlines, the outreach, and what we've done to try to help people stay at home and stay healthier, it's had a dramatic impact. Our home health agency has been a key driver of keeping people home as well. Also, I would say that we put in a new program that's working extraordinarily well called Observation at Home. And we have more than 100 patients that have taken advantage of this program that has remote vital monitoring capability along with home oxygen supplies. So we've allowed our patients to really convalesce in the comfort of their homes where it's appropriate.
And are you being reimbursed well for that observation? Is that like an observation unit that you're doing at home?
Yes, and the answer is no. So the reimbursement has not caught up to anything that we're doing. And I think that, there's some understanding of that. There's no playbook for anyone right now. There's no playbook for us, and there's no playbook really for the federal government in terms of how they're trying to distribute reimbursement for the various things that we're taking care of. And so I think what's happening are sort of these kind of large blanket approaches, and hopefully over time, in seeing what's been effective, we'll be able to keep in place the things that work and help us keep our patients safe, stronger, and more independent in their homes.
Right. And one of the other things I wanted to ask you, Amy, is I understand as you bring procedures back, you're doing them only in the hospital. Is that right? You're not doing them in ambulatory settings or outpatient settings?
That's true for the most part. And that's really to protect our PPE, our personal protective equipment. We still have a resource balancing that we have to do to make sure that we are ready at all times for any hotspots or any surges that might occur. So we are moving forward cautiously to ensure that we have the resources at the ready across our health system to deal with anything that might occur.
What are you doing, Amy, in terms of testing patients as they come in and staff as you start to bring these procedures back?
Right. So we have a program where we test our patients for active virus, whether they are antigen positive or not. We do that within 3 days of the time of their procedure to do our best to make sure that we are working with people that are COVID-free. And the reason for that is that when someone has COVID, they might have more complications. And so we try to reduce the complications where we can delay the surgery. But we have operated on people with COVID because their condition needed immediate care. So it's not a straight line. We try to wait when we can because it's safer. And we want to know to the extent we can if somebody is asymptomatic COVID. so that we can take extra precautions for us and our team members.
And so as you think about that and bringing patients back again, what's the struggle for you in just convincing patients that, hey, it's safe to come back to the hospital now?
Yes, I think that people generally trust their care providers. And so to the extent that they're talking to their physicians about the urgency of their healthcare issue, we find that people are comforted by that and they feel confidence in that. I think the other thing that we're trying to convey is what it's like at Atlantic Health System. So I think one of the very interesting things is when I would go home from work at Atlantic Health and watch the news, I would be scared. I would actually be afraid because I would see chaos, and it created fear for me. And then the next day, I would go back to any one of our hospitals and I would see calm, confident, competent, coordinated approach to care. And so I think that when patients see that, when physicians see that we're not just safe for one moment in time, and I do think that there's an interesting narrative that is happening now in our field where it's like, well, we're going to certify this unit safe. My point is, well, that's certified for about 5 minutes, right? And so what we need and what we have deployed at Atlantic Health is always. We are always safe. We have checklists. We are cleaning hourly. We are cleaning daily. We are treating our surfaces, our air handlers, our filters. We have this continuous commitment to safety. Because as I mentioned to many people, when you get on an airplane, you assume that your pilot doesn't want to die. And that they're doing their checklist not only to make sure that they're safe, that the passengers are safe. And that's the way we look at it at Atlantic Health. No one here, no one of our physicians, no one of our team members, they don't want to get sick. And they're protecting themselves as much as they're protecting everyone that comes in the door. And that messaging, I believe, is getting through to our patients because we're seeing really significantly less resistance to doing the kinds of things they need to do to protect their health. They see that, they tell their friends, and that is building our momentum for safety, which is really the future for our continuous readiness that we need to all be in this next phase.
Right. Well, great. Amy, we appreciate all the time you've taken with us today. We know you've got a crazy busy schedule. So thanks again for taking some time and good luck with bringing back procedures, and please stay safe.
Thank you, Matthew. Thank you for your time and everything Modern Healthcare is doing. I want you to know that the appreciation that your magazine has presented to our providers has been palpable. And that sense of caring and trust is incredibly important right now with the media. So thank you for what you're doing.
Thanks very much. And now I'd like to bring in Modern Healthcare's finance reporter, Tara Bono, to talk a little bit about some of the issues that we covered with Amy. Tara's written extensively about hospitals bringing back some procedures as well as some of the financial implications they're facing. Tara, thanks for being with me.
Hey, how's it going?
Good. So you heard Amy at the outset talk about the financial pinch that Atlantic Health System was seeing from curtailing elective procedures. You've got a story running in this week's issue about the pinch profit margin that hospitals are seeing. Talk a little bit about what you heard from people in the industry.
Yeah, providers are very eager to get back to normal. The amount of revenue they're losing right now is just unprecedented. That's because they're both putting off the most profitable procedures, their bread and butter surgeries. At the same time, some of them are treating these very expensive COVID patients. ICU care is not a huge moneymaker. It's unpredictable. It's very resource intensive. The American Hospital Association predicts that hospitals will have lost a cumulative $202.6 billion between March 1st and June 30th. But you hear these specific examples like the one Amy just gave, $100 million at Atlantic Health. An official with UW Health said that they're losing about $100 million in net revenue per month. I talked to Wilmington Health for a story that's coming out today. They're the largest multi-specialty practice in North Carolina. They said their revenue is down 53%, and worst case scenario, they might just have to sell their practice. But I think providers at the same time understand that reopening is going to be much harder than shutting down was.
Yeah, I'd imagine, and those numbers are pretty staggering. And one of the other things you've reported on, you've looked at how CMS, as well as the AHA and others, have put out some guidance on how hospitals should bring back procedures. CMS has left a lot to the states and localities to figure this out. As you've reported that story, what did you hear from folks in the industry of how they start to do this, and how much are they going to follow the CMS guidance, since it is, really left up to the localities?
Yeah, I mean, providers can't, the guidelines, they can't be too prescriptive because everybody's really, everyone's a different size, everyone's seeing different levels of COVID demand. I think, they're all dealing with different demand levels, so it's really impossible to come up with specific numbers that fit everybody. The guidelines, for example, I thought the most interesting thing was they can't tell providers to test all their patients before they come in for their elective procedures. So in fact, the guidelines from the CMS, from the AHA and other groups, they don't really say, you need to test every single patient before they come in for an elective procedure. So I've heard from interviews with health systems that a lot of them, in fact, are doing that. They are testing all their patients, but not everyone has the test capacity to do that right now, unfortunately. So I thought that was a really interesting variation. There's also a lot of variation on whether they're testing all of their employees. Some of them are, I think they all say they're screening all their employees, but of course that doesn't mean going through with the full COVID-19 test. So screening for symptoms, everyone's screening all their employees and patients for symptoms. But as far as whether they're going through with the full testing, there's a lot of variation on that. Right.
And lastly, Tara, are there procedures that folks have told you that they really want to try to get back in the door, either because they're high revenue or they're things that they're just trying to usher back in quickly?
I think you're really seeing them, like I think Amy said, you're seeing a lot of them breaking them down into categories based on severity. If this patient is really going to rapidly decline, it's my cat.
Your cat. Sorry.
If people are going to
doing everything new.
So yeah, you see them dividing the cases into, if like I heard the chief of surgery at Cedars-Sinai, he said, if they need to be done in fewer than 4 weeks, we're going to put them into this category and they need to go first. It's often a lot of heart procedures, it's cancer surgeries. But then, what can be done within 4 to 8 weeks and what can wait longer than 8 weeks? Before that, you see them also breaking down into, are these ambulatory cases? Can they just be done in an ambulatory setting? And then there's a lot, different preparation that's involved in that. And then which ones have to be admitted? There was a call on their earnings call 2 weeks ago, Community Health Systems' chief medical officer said that they're really prioritizing high throughput outpatient procedures that can, people who can quickly have their procedure done and go home without taking up a hospital bed.
Wow, interesting. Well, Tara, thanks for joining us with some of that insight. We appreciate all your reporting. Stay safe over there.
Thank you.
And be sure to tune in next week when I talk with the CEO of Ohio Health. He's a former combat pilot and emergency physician. We're going to delve into the process of building a command center to deal with this pandemic. I'm Matthew Weinstock for Modern Healthcare. Thanks for tuning in and stay safe.